While performing PTMCs, optimal inflation of the balloon across the valve is usually taken as a surrogate for optimal procedure. But beside that, you should always keep in mind two other things, that either you have inflated the balloon in LV or you have used a small balloon. So coming to the case history, our patient is 44 years old female. She's a known case of severe MS, and she underwent PTMC previously in 2016. She enjoyed quite a symptom-free period for a long time, but again, in 2022, she developed symptoms with the development of severe MS. So she again underwent PTMC in some other hospital in 2022. Few weeks later, patient started developing symptoms again and presented to us with NYHA class 3. This was her echo done few months later after her procedure, and it showed development of severe stenosis with a valve area of 1.1 centimeter square. So the question here is either she had a recurrence or it was a failed or suboptimal procedure previously. So we cannot comment on the second one, but data has shown that recurrence as early as within first year of PTMC can occur, though it's rare, but it can. So considering the favorable morphology of the valve, she was again planned for PTMC. So procedure was proceeded in a usual way, and Inouye balloon of 26 was used. So after a couple of optimal inflations, no fall in gradient was observed. So the clips were reviewed, and after later thought process, it was noted that the inflation was not exactly across the mitral valve, which is clear. I hope calcification of the mitral valve is visible to all. So the balloon was then pulled back using calcification as the landmark, and it was re-inflated. So after a couple of inflations, this time a fall in gradient was observed. So in the second picture, a clear indentation can be seen at the lower border of the mitral valve, of the inflated balloon, sorry, which is when it was rightly inflated across the mitral valve. So this indentation cannot be appreciated in the first picture when it was inflated slightly below the calcification. So measuring the distance between spine and inflated balloon, all it took was just a 4 mm pull back, which gave you optimal results. So localizing mitral valve is of paramount importance while performing PTMC. You can take help from the presence of calcification, as we did, or you can perform LV gram while balloon inflation. We didn't do the one because it was not justified, as the calcification was quite visible and patient had slightly impaired LV. So thanks to Dr. Sohail Aziz for providing us with this video. So pre-PTMC, there was a gradient of 21 with a mean LA pressure of 33, and after procedure, it dropped to 24. Valve area of 1.75 centimeter was achieved. Fortunately, patient developed no significant MR. I think the video has just turned a little bit. And patient developed residual ASD post-procedure because of repeated attempts. So disappearance of the waist should not be considered as the sole criteria for optimal PTMC. So whenever you are not observing any fall in gradients despite optimal balloon inflation, do consider the possibility of inflating the balloon in LV. Thank you so very much.
Any comments?
Okay, thank you for the presentation. Sometimes, especially after when you are considering re-PTMC and already done, especially 10, 12 years back, so this might happen because this is the severe mitral stenosis in all part of the world is just because of the rheumatic heart disease. So the issue when you are just considering re-PTMC, these issues can arise so many. And the other important thing, again, when there is a bed indentation, as you have pointed out, So it clearly, we clearly seen that that was not at the optimal position. So you are right, when you are doing the PTMC and there is no gradient fall, so you will consider this might happen. So this is very excellent. Thank you.
That's what I am thinking, because usually post-procedure you do pressures again and they will tell you whether you're perhaps properly dilated and taken care of the obstruction or not. So, any other comment?
One of the predictors for the successful PTMC is that you should do William Wilkins score before doing the PTMC. If the William Wilkins score is high, so there is a lot of chance you are end up with unsuccessful PTMC, and their chances of redo PTMC in the future is very high. So one of the measurement for this in the William Wilkins score is the subvalvular apparatus thickening. If thickening is there, so if score is high, then the chances of unsuccessful PTMC is high. So what was the William Wilkins score in this case? How high?
Exact calculation is needed. It's not just high.
The
11.25.
Wilkins score was well around 10, and this was a surgical turn down case. This was having, the calcium was visible on fluoroscopy. My routine is to do fluoroscopy before starting the case. And today I told all in the training village also that I do fluoroscopy to look for the calcium before I start the procedure. So it was right there, but this was a surgically turned down case. She was having an impaired LV. Whether this was due to tachycardia-induced cardiomyopathy, or was this, because this was a middle-aged lady, probably she was having some coronary artery disease. But I could not do the coronaries because she was already having impaired LV and the mitral valve, I thought, and she really improved. And I asked her, with first PTMC, she improved a lot. With the second, she didn't have any improvement in the dyspnea. With the third one, which recently, and in between there were many stories. She had iliac artery perforation, we postponed, and then she had an LA clot, and then after, this is a long story of this case, but I will cut short, that she improved a lot after this PTMC. And the indentation in this case, which was seen, that was due to calcium. And when you can see in the video, we went up above and the indentation gave way. So this was just to demonstrate that this was on the mitral valve, so this was just for that purpose. Actually, that indentation gave way and the mitral valve was open, and that was shown one of the commissure. The lateral one was open and the medial still, which was very much calcified, that stayed.
Dr. Irfan, while you were doing it, actually, and you wanted to highlight this point, that the positioning of the balloon is very important. It was a little down and it was not giving results, and so you optimized the position and it was through the valve.
Yes.
So without giving an injection in LV, how you realize that I'm not at the right position and I must pull back a bit and then dilate it?
You can see the mitral valve.
Yeah.
And you were monitoring the gradients as well at that time, that
Yes.
they're not going down, so this is the reason that probably I'm not in a position?
Actually, what happened in the mid, the balloon came out even out of the LA. And then we brought the echo, and I just reviewed. They were doing the echo, and because the gradient was not down on the monitor. So they brought the echo and looked for the gradient that was still up. And I was reviewing on the monitor, then I saw the calcium, and the balloon was well down the calcium into the LV. One point, if it is in the LV, between the cardi, so it will cause MR and it will not expand properly. But if it is properly placed in the LV, it will expand and it will displace the cardi, and you will not know. So two of the reasons that the balloon cannot, the waste disappear. So it is either in the LV or you have taken a smaller balloon in which the waste disappear but the valve is not open.
Irfan, if you keep the transesophageal probe there,
Yes.
it becomes much easier to know where you are.
So there are
And I
many
think
ways to do.
This is
but
the best thing to do.
Unfortunately,
Put a transesophageal probe and you will understand.
yes, sir, that's the ideal.
Okay, great case. Thank you. Now let's move on to the next case.